Hello friends, this is a case of laparoscopic fundoplication and we are starting the varus needle supraumbilical. So this patient has grade 3 GERD and all the other means of the procedure has failed. So we are performing the laparoscopic Nissen fundoplication. Here irrigation, suction and hanging drop test is performed. And it is confirmed that we are inside the abdominal cavity and now pneumoperitoneum is started. Here we are keeping the preset pressure at 15 millimeter of mercury and slowly waiting for actual pressure to reach, and flow rate is 1 liter per minute. For doing the access, always you should stand left to the patient. However, once all the port will be introduced, then you will go in between the leg. But if you are a right-handed person and if you have to put the port in any surgery, either you do bariatric or you do fundoplication, Heller's myotomy, then always stand left to the patient to put the port, because if you go in between the leg in the beginning of the procedure, you cannot put the port. So we can see that pneumoperitoneum is slowly getting established and we can see the homogeneous distension of the abdominal wall is already started, and almost the slowly the actual pressure is reaching to the preset pressure. During the initial pneumoperitoneum, why pressure should not be more? Because if more than 1 liter per minute, if it goes to any vein, then it can create air embolism. So that's why slow insufflation is mandatory in the beginning if you are using varus needle. So now almost pneumoperitoneum is complete, and then we are just waiting for actual pressure to reach to the preset pressure. By the time your camera person will prepare the telescope with the white balancing, focusing and cleaning and warming in the flask of the thermos, you should keep the boiled water and then it should be introduced. Now we are enlarging the incision to 11 mm to just put the optical port, and that is also supraumbilical. That should be approximately 18 centimeter below the GP sternum in normal patient and 22.5 centimeter below the GP sternum in bariatric patient. So it is done pneumoperitoneum, and now the optical port is introduced, and after that we will put the epigastric port for Nathanson lever retractor. This should be just below and little left to the GP sternum, so that we can easily introduce the Nathanson lever retractor. But Nathanson lever retractor will be introduced percutaneously. Initially this is 5 mm port, but later port will be removed and it has to go percutaneously. Now this is the third port, that is the approximately 3 to 5 centimeter below the costal margin on the left side. This port will be our right hand for ligation, harmonic or the dissector. Once you will stand in between the leg, then all the active instrument will go to this port. Now fourth port will be just below the costal margin in the mid clavicular line. So if you see, fourth port is little up. Why? Because esophagus and gastroesophageal junction is little left. So that's why fourth port should be kept little up. That is important when you are doing the fundoplication or bariatric surgery. And fifth port should be anterior axillary line at the level of the umbilicus, and that port will be used for the assistant to hold the short gastric. So this way all the port has to be introduced first, standing left to the patient. And now this is the last port which we are using, that is the fifth port. It is the anterior axillary line at the level of the umbilicus. Basically this is the assistant port. So we can see all the port is introduced and all the other ports are introduced under vision. After that you will shift to the in between the leg and then surgery will be started. Patient head will be put 30 degree down and now this is the Nathanson lever retractor which is getting introduced. Initially it should go perpendicular, and after that once the tip of this Nathanson enter inside, then you have to rotate clockwise direction. So basically it goes percutaneous, it is not going through the cannula, and then you will fix it with the stand of the Nathanson lever retractor. And now you can see we came in between the leg, and now the surgery is started. Right hand has right now the ligature, or left hand has a grasper. So this is the stomach. We can see Nathanson is lifting the left lobe of the liver anteriorly, and we can see there is some adhesion in this stomach with the posterior wall of the liver. So first thing what you have to do to remove those adhesions, and then we will go ahead. So here we are using the bougie first initially, and we should try to deflate the stomach and then take the bougie out in the esophagus. It should be pulled inside the esophagus. So we are doing little bit adhesiolysis. With the left hand has a grasper which is giving traction to those flimsy adhesion, and right hand has a harmonic which is doing adhesiolysis. So this process should be carefully conducted because the tip of the harmonic should not touch the liver. If it touch the liver, it will do the knocking effect, and then it can start bleeding. So we can see now we have opened the pars flaccida, and the below is the caudate lobe of the liver. So in this process we have removed the adhesion, and now once you will go little towards the superior aspect, here the pars flaccida is cut, and now we can see this is the esophagus, here is the fundus, and this is the gastroesophageal junction, and this is the spleen. So little bit more pars flaccida is cut. Regardless of the obesity of the patient, pars flaccida is mostly transparent, which is covering the anterior wall of the, you can see the caudate lobe of the liver is visible, and below this caudate lobe of the liver is vena cava. So whenever you perform any surgery, you have to be careful that if you are doing the crural approximation or you are taking a bite in the crust, for that means you should never try to go little deeper in the liver. Otherwise, here we can see we are lifting the caudate lobe of the liver to show you the vena cava. This is the area of the vena cava, and this is the crust. Now, one of our first step of the surgery is that at least 10 centimeter of the stomach should be mobilized from towards the fundus, so that you can have a floppy fundus and you can do a floppy fundoplication. So all the short gastric of the upper 10 centimeter of the stomach will be separated, omentum will be separated. So here assistant has a role, assistant can hold it, and with the right hand right now we are using ligature, and with the ligature it will all the momentum of the upper part of the greater curvature at least 10 centimeter will be detached. So we can see in the first step of this detachment will be that you have to make a retrogastric tunnel so that posterior wall of the stomach should be visible, and we should avoid doing any collateral damage to the stomach, should not burn. Generally in sleeve gastrectomy we want to remain as nearer as possible to the stomach, and if a stomach burns it is good because there will be no problem, because ultimately a stomach has to come out, but here burning of the stomach should must be avoided because the stomach has to retained in. So slowly this is separating, and now once the full layer will be separated, then posterior wall of the stomach will start visible. So we can see now this posterior wall of stomach is visible. Now the left hand will hang the posterior wall of stomach, and then the dissection of the remaining will be easy, because like I showed you can catch the pedicle easily and you can continue till the left crus. So now we have reached up to the spleen, and in the we can see there are some adhesion with the spleen which is always found, and you should try to find out that at that time you should not avulge the parenchyma of the spleen, otherwise bleeding will start. And this is the last part of the fundus. This is the most crucial part as far as bleeding is concerned. So you should be very careful that tearing of the parenchyma of the spleen should be avoided. And now here we will start separating the peritoneum over the left crus. After separating the adhesions of the spleen, now peritoneum of the left crus also will be separated. We can see these are the interior mobilization of the esophagus is started by just cutting the peritoneum, and the left hand should give the caudal traction, and this is the interior mobilization, and this is over we are right now over the left crus, and slowly a U-turn will be taken to come to the opposite side. So this is the lateral mobilization of the left side, which is with the peritoneal cutting. You should try that you should remain only at the peritoneal level, you should not go very deeper, and left hand has a lot of role that will give you anteromedial anterolateral traction, and this is the crus which is clearly visible. This is the left crus, and this is the anterior mobilization of the esophagus which is started, and left hand is giving the right side traction. Now we will go to the right side, and for that we have to go just at the level of the right crus, and the peritoneum should be separated at the level of the right crus. So, this is the caudate lobe of the liver, below is the vena cava, this is the crus, this is vena cava down there, and this is the crus, and you will get a demarcation line with the peritoneum with the muscle will be clearly visible. And now we are using harmonic to do the lateral mobilization of the right side. An assistant is pushing the stomach caudally so that fundus also will be pulled down. And this is cutting the peritoneum of the anterior as well as right side, and this is the posterior mobilization of the esophagus. This is the most crucial part of the dissection of the fundoplication, where you have to separate and you have to make a retroesophageal tunnel, that is the posterior mobilization. And anterior vagus is almost embedded. You should take care that during the posterior mobilization, posterior vagus should not be broken, it should not be burned, it should not be cut. And we should try our maximum to do the blunt dissection, and for that it is always better to avoid energy and better to use grasper. So, assistant is pulling, and here this is the vagus nerve, we can see here this is the vagus, and we are pulling the vagus anteriorly. Always better to keep the vagus towards the esophagus is a good idea, and the right vagus also is visible, you can see above the Maryland, and the left is also visible, and now slowly this is the tunnel, posterior window is getting formed. This patient is a thin patient, so there is no much difficulty, no much fat, and anatomy is very clear. So, now we will bring our instrument, that is we are very useful, especially called gold finger forceps. Mostly we use this to make a posterior window. This is a fantastic instrument, and this instrument is basically by the Covidian, that is called gold finger forceps. So, this is the right hand, you can see outer vision of the gold finger forceps. It has a finger like projection. So, once you will enter inside, it bend in any direction, and it is 90-degree, it is bending all around. So, you can hook the posteriorly the esophagus, and you can enlarge the posterior esophageal window without creating any trauma, and this is very good instrument, and you can see almost surgery is finished. We have a good posterior window, anterior as well as posterior mobilization is complete, and after that we will pull the fundus from left to the right posteriorly, and then it is a floppy fundus which is coming very easily without any problem, and then we can see the shoe shine effect. We can check it that it does not have any tension. So, we can see this is called shoe shine effect. It is showing you very nicely, and there is a floppy fundus, there is no traction over the, and now your assistant, you will ask that he will keep it pulled, and then we will do the next step, that is a crural approximation. So, advantage of keeping it pulled, that you will get some space to do the crural approximation, and here we will approximate the right and left crus. How much bite should be taken, because here there is only a small defect, so it is only 1 knot is required. In the large hiatus hernia, sometime 2-3 knot is also required to approximate. And when you take bite on the muscle for the posterior approximation, we should be careful that only muscle should be taken. Accidentally, you should not go deeper to the caudate lobe of the liver, otherwise you can prick the vena cava. So, you can see that muscle is taken, and now this needle is coming out, and then we will tie the knot. So, here we are using Ethibond 20, that is the polyester suture for the crural approximation. And this is simple surgeon's knot, because there is no large hiatus hernia, otherwise you have to use tumble square knot, or extracorporeal square knot, but here simple surgeon's knot will do the job. When you close the, when you approximate the crura, you have to be very careful that at least one 5 mm opening should must be present in between the crust and the suture. So over tightening should must be avoided, because that is also one of the cause of the dysphagia if you will over tighten the crust. However, it should not be loose also, and it should not be opened also. Otherwise, there may be a strangulation of the entire wrap in the chest, especially in hiatus hernia. It is possible to do. So it is very careful that it should be optimum closure should be done, and we can see the muscles of the either side of the crust is approximated, and then you will cut the suture. Now the next step of the surgery is just suturing the wrap. So we will start suturing, and in the first suture we will take only a stomach to a stomach. In the first bite, esophagus will not be taken, and in the second and third bite we will include the esophagus. So this is a full thickness bite on the stomach, and this is the 360-degree Nissen fundoplication. Final suturing is started. And this is the right hand, you can see the needle holder, left hand has a grasper, and this is you are standing in between the leg, and you can start the surgery with the Maryland and the needle holder here. Suturing is started, taking a bite and suturing it. So slowly the surgeon's knot, multiple surgeon's knot will be applied, and 3 to 5 centimeters should be the length of the application. We should not have very short application. Here suture is little small, that's why needle is held. Otherwise, directly holding the needle should must be avoided, because that creates sometime the pricking over the spleen or diaphragm, and that can be dangerous. So better if you feel that your needle end is short, then better to cut the needle end, drop the needle, and then you do the suturing, because holding the needle and taking a wrap by holding the needle is little dangerous in this area. So this is the surgeon's knot. So first time double wrap was taken, followed by 2 opposite alternating wrap. So now this needle is immediately taken out, because if it drops anywhere and it can disappear, and now another needle was introduced to start the further suturing. So in the second bite, we will take the muscle part of the esophagus also. When you take the bite in the esophagus, you have to be very careful that it should be just superficial muscle, because esophagus doesn't have serosa. So if you have to be careful, and this is the second bite, we can see little pricking the needle sometime create little bleeding, but as soon as you will take a bite, it will stop. Once you tie a knot, it will stop due to pressure. So this is again second knot, and first time double wrap is taken already. and this is the last knot of the second bite. So this is second knot. And now we will take the last knot. All the suture we are keeping over the stomach, so at the end you can take it out, and this is the last knot of the surgery. So all the three here which is used is the surgeon's knot. And it's over. After that, carefully the needle and all the cut suture will be taken out. Now we have to very carefully remove the Nathanson lever retractor as well, and for that, once you will release this and then you do the, you can see there is no bleeding, everything is fine, and now slowly the Nathanson will be taken out. So thank you very much for watching this video. This was just a simple case of Nissen fundoplication by laparoscopy. Thank you very much. Have a nice day.